This is Jerry Hesch of the Hesch Institute in Henderson, Nevada, very close to Las Vegas. And this is our client Lori, who had Harrington rods placed in the lower thoracic and lumbar spine when she was 15. Okay?
Yes.
And so you'll probably notice that her whole spine is very rigid. You'll notice the shoulder girdle is very rigid. She has reduced arm swing on the right. Okay, so you'll notice her right arm is not moving quite like the other one. Now, I don't see it. Maybe you do, just subtly. You'll notice the left elbow. If you look at the space between the elbow and the pelvis, that becomes much more reduced than on the right. You'll notice that on the right now, that space is preserved, the space between the pelvis and the elbow and forearm, whereas on the left, you'll notice that it closes. Okay, so once again, right here, you'll notice that space closes. Keep going. And then if you look at the other side, you'll notice that it's, some of that space is preserved. So her pelvis is shifted over, and it's shifted over to the left side. So now we're going to have you come lie on your back with your feet down at this end. Now you mentioned that you had a leg length inequality, but I disagree with you. Put your legs out straight. There's no evidence for a leg length difference when you're laying down, but we do know you have a difference in hip range of motion and your pelvis is very asymmetrical, so that's probably feeding into that. Now, the hip rotators on the left, I'm testing them by twisting the whole leg, twisting the hip into internal rotation, and that is probably 35 to 40 degrees, and there's a soft end feel. On the right side, and you'll notice that this one lays out more than this one. Okay, this foot points outward because of the rotation up in the hip. So when I roll you in, I have to roll you about 30, 35 degrees just to get to neutral. Okay, this one over here is laying out to the side about 20 degrees. All right, so this one I roll him in, and now the foot's straight up and down. And guess what? You have very little motion beyond that, about 5 degrees. Push as I may, there's no further gain. So very, very tight hip rotators on the right. On the left, again, we can roll you in easily to 35 degrees or more and gain some additional motion. You do have really good hip range of motion. We did a scour test on both hips. You've got kind of a clockwise test. You've got good motion on both sides. You do have full hip flexion on the left, almost full, but we know that at about 60 degrees you start to, the left sciatica enhances. The other finding, it relates to the right hip. And that finding is that when I spring this femur, I can load it, and then I can create some bounce. On this side, I can't even load it. It's very, very rigid. There's no spring. Now, if I roll the leg in so that it's lying at the same angle as the other one, I still can't load it. I still can't spring it. Even if we're straight up and down, same thing. Whereas this one, again, I can push into the femur, load it, and then spring it. That indicates some forward mobility inside the hip joint. The left knee, you can feel that in the popliteal space, and you can feel that one also. The patella, I can squeeze it on both sides, and it lifts up towards the ceiling. On this side, I can't even squeeze it. So you're functioning with patellofemoral compression, and that has everything to do with the hip. Let's have you lie on your stomach, and I'll show that in a little bit more detail. So I'm suggesting that the right hip is stuck in slight flexion, slight posterior glide, and if we test hip extension, I get about 5 degrees. On your left, free and easy. Free and easy, 20, 25. Okay, significant difference there. Now in this position, you have rather adequate hip rotation, okay? And you go to about 45 degrees with kind of a normative end feel. So there's a big difference in context when you test hip rotation. This is a little bit freer, but basically one would call it normal on the right-hand side. And this is the traditional way of testing hip rotators length, which I, of course, disagree with. I think it's much more important to test when the leg is out, when you were lying on your back in that context. Another way of testing that is to spring the trochanters here, and the right trochanter is very posterior, and I don't think you can capture that with a camera, but it's clearly about an inch more posterior. When I capture that trochanter and try and spring it, there's no give on this side. Yes, I can spring, and you can see the mobility goes through the hip joint on down to the lower extremity. All right? Let's have you lie on your back again, please. We spoke of the pelvic side glide. Put your legs out straight. I'm going to glide the pelvis from the right to the left. So we load it, okay, and you can see that it moves a certain degree and then it stops. And I can then spring it and create an additional amount of movement. That's called a spring test. On this side, you'll notice that it loads so quickly and I cannot create any additional movement. So we interpret that as the pelvis being shifted over to the left. We call it lumbopelvic side glide to the left. It involves so many structures. It involves the pelvis moving on and with the hips, moving on and with the lumbar spine. We know you're fused at L5S1, and then you're fused from L3 all the way up to T11, okay? So some of that side glide motion is happening at 4-5, some of it's happening in the hips, with the pelvis moving with the hips, and then some of it happening higher up in your trunk. There is another asymmetry with your pelvis, and that is that you have a classical right anterior ilium, left posterior ilium. That's actually just a twist of the whole pelvis. I'm not implicating the SI. But Mark, if you want to bring the camera along, come into the room, you'll be able to get a better sense of this, probably on the side here. The right pelvis, the right ASIS, is more forward towards the ceiling, and you may not see that, but that's all right. But the anterior shelf, you can see, is much lower on the right relative to the left. Okay? So the terminology is that you have a right anterior ilium and a left posterior ilium. I'm going to suggest that's a movement of the entire pelvis, and that it's not indicative of what is called sacroiliac joint dysfunction. It's not that your ilium twisted on the sacrum and got stuck, and I'll show you why I believe that in a short while. But we do passive mobility testing, and I'm taking up the slack, rotating the ilium further posteriorly on the left, and then I impart a little bit of force, and because there's a little bit of give there, I believe that there is mobility inside your left SI joint, which of course was fixated, right?
Right.
You've got 2 screws in there?
Yes.
Okay. We're going to test the right side now, and we're testing posterior rotation, and I take up the slack to an end point, and then I spring it. And there's not a whole lot of mobility, but there is a little bit of yield. And so I do think that your SI joint on both sides does have mobility, and the CAT scan did show that there was a normative joint space on the left. The CAT scan, the radiologist concluded that your left SIJ is not fused, in spite of it having some hardware. Okay? So we have a right anterior ilium, left posterior ilium. There's also a transverse plane component to this, in which the pelvis is twisted to the left in the transverse plane. It's easier to see that when you're on your stomach. Let's have you lie on your stomach now. But we're going to get your face down in this opening down here, okay? So I'll take your sunglasses. Thank you. Now again, she had a significant scoliosis and had Harrington rods. So you see some of the effects of that, in which the paraspinal mass is much more prominent on the left side of her body, and then it starts to counter-rotate. So she's lying prone now, and she has more muscle mass on the left all the way up here, and then it reverses up here. Okay? Now when she alters her posture, that may change a little bit. You'll see that change in child pose, and now the curve reverses, where she has more tone up here. Okay? So more tone here, more tone here, more tone here. All right? You'll notice that probably in response to the surgery, she does not have any rib mobility. Push as I may, I can't create any rib mobility until we get up to about rib number 5. Okay? And that's consistent on both sides. There's some rib mobility there, but down here there is none. Okay? Now just a reminder, she's fused from T11 down to L3. She's also fused at L5S1. However, and she has significant degeneration at L4, L5, and is facing another surgery there in the near future. I can't actually isolate the mobile segment of 4. I can't find it with the passive mobility testing. Looking at the upper spine, she does have good vertebral mobility. So I'm springing T3, T2, T1, and there's good mobility. And we come down to here, and there's no mobility there. So you actually, have distinct reduction of thoracic mobility in the mid-thoracic spine. The second and first ribs do not move. Second rib is right here, absolutely does not move. And the first rib is right here, no movement there on either side. Her scapulae are very elevated, okay? And the spine of the scapula is so high up, and I cannot create any inferior glide. I certainly think we can gain some motion there. Let us have you lie on your back, please. And I don't know where your sunglasses is. I walked around, I put them somewhere. Oh well. That's called the Hesch method. All right. This shoulder is very forward. I can create some spring mobility in her left left AC joint. Okay? I can spring the clavicle inferiorly, take up some slack, and then I can push, and the movement goes through that structure. Same with respect to pushing towards the floor, posterior glide. On this side, that clavicle is so restricted, I cannot create any inferior mobility. I cannot push it towards the floor. In terms of springing the AC joint, it is so compressed. I think that we can help those. I'll be thrilled if we can restore mobility there. And then coming in from the top down onto the first rib, you encounter the first rib so quickly. And the first rib is elevated and it's also compressed, and there is no give there. And then if we come laterally and deep onto rib number 2, there's no give there. But rib 3 is mobile. In the front, you can't touch the first rib. You can only spring on the medial clavicle going towards the floor, and there's no give there. We can spring inferiorly, no give there, no give there. And the second rib is just below that, no give whatsoever, springing towards her toes. And then we come on to number 3, and you can see that you can freely create movement through that structure and inferior mobility as well. I did screen the upper cervical. She has good upper cervical mobility. I kept looking for a compensatory rotation up at the OA joint, but I'm not finding it. So all of her compensation for the pelvic and hip asymmetry happens below the upper cervical spine. That's fairly unusual. Usually there is a compensation up high, but I'm not finding that. So let me look at my list and see if we're complete. I know that we need to get you up in child pose position. Let's have you get on your hands and knees, please. And get up in child pose. Good. And she has symmetry of the sacrum in this position, and there's consistency in the asymmetry of the pelvis. And you can see that the right iliac shelf is much higher than the left shelf. And the muscular asymmetry enhances in this position. There is much greater tone, quite rigid there in comparison to the right. So she has much more tone all the way down on the left side, and then it counters. So now she has more tone here, and that goes all the way up to about T2, and then reverses, same as it does when you're lying on your stomach. Now, I don't know that I have easy access to a flexible ruler. I own one, but I think it's in my teaching supplies. So unfortunately, I can't put my hand on it. It would be interesting to use that flexible ruler and check the curve throughout the spine in full flexion in this position of child pose, and then do it with you up on your elbows. And I'm going to suggest to you that part of your thoracic spine above the fusion does not move. I think that we're about done. Just one more thing that we noted, go ahead and relax, and that is that when you sit, the right femur is a little bit higher, and that has to do with the asymmetry of the pelvis, the asymmetry of the hip motion. We're still filming, right? Good. So in summary, what I think that we can affect is the restriction of hip rotation on the right, the lack of hip extension on the right. I'm curious to find out how much we can alter the right anterior ilium, left posterior ilium. And that's a three-dimensional problem. So we want to change it in the frontal plane, sagittal plane, and transverse plane. I don't have a big expectation for changing the asymmetry of tone up the spine. That's more related to your surgery. It might change a little bit by getting more symmetry of the hip and pelvis, but that's not high on my list. Very much would like to increase mobility in rib number 1 and 2 on both sides, and in the right AC joint. I'd like to bring those scapulae inferior. They're so elevated. That's the spine of your scapula. They're just so very, very elevated. And so I would like to address those things. It, of course, would remain to be seen what we can accomplish and how much of that feeds into your symptoms. I think you and I and your physician are on the same page that something has to be done at L4, L5. I think that's a given. Maybe we can take stresses off C6, C7, where you have a upper cervical neuropathy that gives you radicular pain all the way down. Maybe we can take a little stress off that. We don't know that. But this summarizes my thoughts at this time, and we'll treat you, and we'll come back and do a repeat film on your second or third visit. And thanks very much.
Thank you.